All right, so we finished off last time talking about types of ossification, how bones develop from fetal development to early fetal development until the time the baby is born. And we talked about intramembranous ossification and endochondral ossification. The major difference is the starting material, right? We talked about the starting material for intramembranous is a connective tissue membrane, and the starting material for endochondral is, you tell me. What is the starting material for endochondral ossification? Cartilage. What type of cartilage? When in doubt, it's always hyaline cartilage. Yeah, hyaline cartilage. So that's the starting material, but the ending material is always compact bone. Compact bone, and then that might be carved out by osteoclasts to make spongy bone. So it just depends on the location, right? But regardless of the starting process, the end result is always the same. So then we talked about how bones grow in length, and it's at that very important part called the epiphyseal plate. What do we find at the epiphyseal plate that allows bones to grow in length? The word of the day is hyaline cartilage. Yeah, hyaline cartilage is found in that epiphyseal plate. So if we look at an x-ray, we're going to see a dark spot where that hyaline cartilage is because it doesn't absorb the x-ray. And it just looks like a dark material there. So that is a sign that the bones are still growing. But if there is no dark area where that growth plate should be and there's just a line, that means it's ossified and the bones are downgrowing in length. So we talked about last time how the growth in length is on this side of the epiphyseal plate and this side is becoming bone. So toward the end of the bone, the side of the epiphyseal plate that points to the end, the epiphyseal side, is hyaline cartilage, and the part that points to the diaphysis side of the bone is bone. It's ossifying. Okay, so if we look at that process, we call it interstitial growth because growth occurs between the cells. So interstitial growth in length. And we talked about appositional growth is when there's bone cells on the surface doing their job. So we said here, remember last time, this is what type of cells are on the outside in the green? Osteoblasts, and on the red, osteoclasts, because we want to make sure those bones grow in width evenly, so we're carving out the medullary cavity so we don't get a really thick bone with a narrow medullary cavity. That would be too heavy and not good for bone. So picking up now today then, we're talking about factors that affect our bones and how we can keep our bones strong and healthy throughout the lifespan. So we know you need good nutrition. We need vitamin D, vitamin C in our diet. Vitamin D helps us absorb calcium from the intestine. So if we don't have the normal amount of vitamin D, our small intestines cannot absorb calcium and use it to harden or ossify bone. So we need that vitamin D to help us absorb calcium. And vitamin C, you can remember it, collagen starts with the C, and vitamin C is necessary for collagen. So we know that collagen is what makes our bones flexible, right? So you would have brittle bones if you didn't have enough collagen. And if you don't have enough calcium either, right? You need both of those to make strong, hard bones. So vitamin C is necessary. So back years ago when we used to send sailors on ships for months at a time and they didn't have good refrigeration methods, the vegetables would not last, and they had a meat and potato diet. Well, as a result of that, they weren't getting enough vitamin C, and collagen would break down, and they would end up with what's called scurvy. And scurvy causes hemorrhaging because collagen in the blood vessels are what keeps our blood vessels intact. And if you don't have enough collagen, blood vessels break, and you have bleeding under the skin and hemorrhaging, and it's a serious condition. So that's why they now sent limes on the boats, because limes keep well. They're a rich source of vitamin C. So what, in the pirate movies, what do they call people that live on ships? Using the word lime. Have you ever heard of it? Limey? Yeah? They call each other limeys. Have you ever heard that in a pirate movie? Well, anyway, limeys. They do, because they have the rich source of vitamin C in limes. Did you have a comment?
No, I just said lime.
Oh, you did? Okay. So anyway, so we need a good amount of vitamin C. So hormones also affect our bone growth, and this is huge. These hormones are essential for growth during puberty. So we need growth hormone throughout the lifespan. Otherwise, babies would stay babies, right? So grow, and they're not producing a lot of estrogen and testosterone. They're producing a small amount, and that's what makes girls girls and boys boys. But the growth hormone really plays a big role, you know, during childhood. And then at puberty, this might be a test question, hint, hint. Not even a hint, direct statement. This is a test question. At puberty, the sex hormones are what really kick things in for bone growth. Testosterone kicks in sooner and kicks out sooner. So if you look at a classroom of, say, kicks in later but lasts longer, estrogen kicks in sooner and fizzles out sooner. So later and longer, testosterone. Earlier and ending sooner, estrogen. Okay? So if you look at a group of 6th graders, who's going to be taller? Yeah, estrogen earlier, starts earlier. So girls are taller, but they burn out. They're done growing. That estrogen effects on skeletal growth ends about age 18. But for boys, they kick in a little later, you know, about 7th, 8th grade, and then they are done at age 21. So males can continue to grow taller in college. But now there's individual differences, right? Some of you may know that among yourselves. Maybe you peaked early in middle school and then you were done. Or some people didn't grow until they're in 9th or 10th grade. So it's really variable on when those, you know, hormones of puberty kick in for people. But nonetheless, so testosterone slows down, you know, as men age. Estrogen production stops for women when they hit menopause, when the ovaries stop producing estrogen. But estrogen is produced in other parts of the body as well, but the primary source of estrogen in women is the ovary. So when the ovary stops secreting, estrogen stops, that excess estrogen that keeps bone strong, and women are really at risk for osteoporosis at that time, because estrogen stimulates osteoblasts. So if osteoblasts are no longer stimulated, women have to find a different way to stimulate those osteoblasts. And we'll talk about that next. Thyroid hormone, that's a metabolic hormone, so all cells need thyroid hormone for metabolism, and part of metabolism is growth. So for those hormones and those cells to do their job, they need receptors for thyroid hormone. So people that have low thyroid conditions in childhood are at risk of poor growth. So it's really important we get kids checked for thyroid. So the pituitary gland secretes growth hormone. So again, that is secreted throughout life. The thyroid gland secretes thyroid hormone, and that we know that the ovaries and testes are the #1 secretors of those sex hormones, testosterone and estrogen. So bones are remodeled. These hormones act on bones and contribute to either breaking down bone or building it up. That's what remodeling is, right? If you say you're remodeling your kitchen, you might be in the middle of tearing everything out, right? So what cells would be involved in bone remodeling that are breaking it down? The old osteoclasts, right? And then when you put new cabinets and flooring in, what are the cells that are responsible for making new bone then? Osteoblasts. So if we want to see just kind of a remodeling, we should have an equal amount of tearing down to building up, right? We shouldn't have one outpacing the other, because if we have one outpacing the other, the bones are going to grow. And in adulthood, like most of us here that are done growing, you should have an equal balance of osteoclast activity with osteoblast activity. But again, what happens if we don't get weight-bearing exercise? That means exercise like walking, running, even weightlifting is weight-bearing exercise because it puts stress on our bones, and that stimulates osteoblasts. So as long as we're getting those that weight-bearing exercise, we're stimulating osteoblasts. Swimming is not stimulating osteoblasts. Light biking, like on a spin bike, not stimulating osteoblasts. You've got to do hard biking. Yes? Those really, really tall people, gigantism, I mentioned that on the previous slide. I didn't talk about it here, but it's a good point to mention, is when we see tumors in the pituitary gland and before the growth plates have sealed, we see excess growth in long bones, and that contributes to what is called gigantism. And that's what Lurch from the Addams Family, if you've ever seen the Addams Family, old black and white show, and Andre the Giant, he was a wrestler, you know, gigantism is what that is, and that's an excess of growth hormone. Or if you have underproduction of growth hormone, that leads to people that have, you know, they're called midgets, right, where they have underproduction of growth hormone, and then those people are really small. And I did have a picture.
What's considered
How about if I show you a picture? Because you can see, if those of you that have kids, you know when you take your kids in for their well check, they put them on a growth chart. There's like a normal growth curve, and your kid goes on there. And it may not, like the child may be on the smaller side, right? So it's maybe not on the average growth curve, but as long as it follows the growth curve and it continues to grow in the pattern that we normally see kids grow, then they say that's normal. But if a child is on the growth curve and just kind of flattens, then we know there's a problem and the child is not growing. So here's an example, gigantism and dwarfism. So here's a person of normal height. There's a person of normal height, person with gigantism, and then a person who is a midget or dwarf.
So there's not like an actual start height once you get this point, you're like known as.
Yeah, well, I'm sure there is when it comes to, you know, again, they use the growth curve as a baseline, as a reference frame, and if you're like way off the growth curve, way up high, then they're going to say, you know, that there's a problem. Oh, yeah. I don't know the number for that. I couldn't verify that. Because a lot of it depends too on race. So some people are shorter stature and that's not abnormal for them, you know, so it just kind of depends. Like a lot of the basketball players, you know, those aren't necessarily people with gigantism. They're just, that's just their genetics. Okay, so we want to have a balance of osteoclast and osteoblast activity to maintain. If we lose one or the other, and we have too much of one or the other, bones are either going to grow too thick, if we have too much osteoblast activity, not enough osteoclast, or too thin. So another time when osteoclast and osteoblast activity is important is when bones break. And bones can fracture, and there's 4 steps of how bones heal. It's important that you know these steps because this will be on the test, the order of steps for bone fracture. So a hematoma forms, number 1, because you've broken those blood vessels. Remember the blood vessels that run down the center of each, what do you call those circular units that make up bone? Osteons. And what do you call the hole in the middle of each osteon? Central canal. See why we do lab before a lecture? So those vessels are down the center there. When you break those osteons, those blood vessels break and there's a leaking of blood under the skin and around the bone. So that's what a hematoma is. A hematoma is just bleeding underneath the skin, and it looks like a bruise, right? It looks really ugly. It swells, and it gets uglier as it heals because that blood starts to dissipate. It might even follow gravity and move downward away from the site of injury. But if you see swelling and bruising and a lot of pain with movement, you're thinking a break. Because sprains can usually move because the ligaments and tendons are, you know, injured. It hurts, but it's not a sharp pain like it would be in a broken bone, because then you're rubbing those broken edges together and there's nerves there that'll definitely send a pain signal. So when it first breaks, here we can see the break, then a fibrocartilage tissue forms to span that break. So this is the healing process, and this doesn't take very long. A couple of days, then a bony callus forms. This bony callus is actually woven bone, which again is very fragile. So if someone is not, say they've got a broken foot and they don't get that looked at and they're walking on that, they're going to keep re-injuring because this is a very fragile bone, this bony callus. This is when it should be in a cast if there's a lot of mobility at this break site. And then bone remodeling, full bone remodeling occurs where we are breaking down and adding new and replacing that area with new bone, and it's not at risk for breaking. If this process went to completion and the bone was well supported during that time, there should not be a risk for a new break there. But what happens if the break is right near a growth plate? Now that could interrupt that hyaline cartilage, formation in a child's growing bone. That can disrupt that very delicate area where both growth and bone length occurs, and then it could be problematic. So they really watch those carefully.
Can you see those? Like if you get an X-ray, like when you see like when they start pulling together?
Well, you can see this early because this won't absorb X-ray.
So does it, okay, because when I had an X-ray done when I fractured my fibula or whatever, I had a boot, and like 2 weeks after I had gotten my boot, the sports doctor said I could take it off and like could walk still.
Yeah, yeah.
Like, because all he said was that it looked white.
Mm-hmm.
He just said it was healing, and so I was fine.
Yeah, that's the bony callus, because that forms in a matter of weeks. And in a young person, the healing of bone is much quicker. So yeah, you won't be at this until months after the break. So we're in a decent spot when you're here. But again, it's woven bone, but it's being added to. So this is strong enough for people to navigate with.
Okay.
When I broke my foot this winter, that was a comment the doctor made to me during one of the follow-ups. You're 31 years old. You can't expect to be healed in 6 weeks.
Yeah.
You're a little bit too old for that.
Well, right, and just think about a person who's 80 years old, who fractures their hip. They're going to require surgery to get things lined up and cooperating. Yes. Yeah. Mm-hmm. The clavicle, because it's supported by the joint at the manubrium and the scapula, I believe, it's pretty well supported. They don't do much for a broken clavicle, and unless it's really, fractured all the way through. But oftentimes they just crack and then they line up again, so they leave them alone. My son had a really bad sledding accident. He had a fractured skull and brain bleed and broke his collarbone. They didn't do anything for the collarbone. They just put his arm in a sling for like a week, and then that was it. And it didn't even bother him that much. There's a bump there now because it didn't heal perfectly, because there is mobility when you move your arms. But yeah, a broken clavicle is usually not a big deal. And yeah, that can happen with big babies, I've heard. Yeah. Okay, so calcium, hugely important for bone growth because the hard part of our bones, we said, is calcium phosphate. So we need calcium and phosphate in our diet to make our bones strong. So when there is not enough calcium in the blood, because we're going to find out this semester that calcium is also needed for muscle and nerve conduction, for our muscles and nerves to work together to keep our heart contracting and all of our muscles working, smooth muscles, skeletal muscle for movement, cardiac muscle for heart function. We need calcium in our blood. We need a decent amount of it. So if we're not getting enough in our diet, then the body has hormones that will kick in that stimulate osteoclasts. So remember, osteoclasts break down bone. So parathyroid hormone is a hormone that is released when blood calcium levels fall. And notice here that I bolded it, and I told you what it does. So it's bolded in the notes, which means this is critical information that we need to know about. So we could ask, what stimulates parathyroid hormone to be released? What stimulates it to be released? What is it? Low blood calcium. Low blood calcium. So if there's not enough for muscle contraction to occur and nerve conduction, then we need to go get some calcium. If it's not in the blood from the diet, like if there's not enough vitamin D to absorb it, like maybe you're eating or drinking plenty of calcium, but there's not enough, you have low vitamin D level, then it can't absorb and get into your blood. It's just passing right through. So then the parathyroid hormone is going to be released from the parathyroid gland, which makes it easy, and that'll be released, and that's going to stimulate osteoclast activity. So that we call this hormone the bone breaker because it stimulates osteoclasts, and we know osteoclasts break down bones. So the parathyroid hormone is the bone breaker. It's a very active hormone because if calcium levels drop, we got to go get some ASAP to keep that heart muscle doing its job. So it has several other functions. It causes calcium reabsorption in the kidney, so if calcium is headed for the toilet or wherever, through the urine, we're going to grab it back out of the kidney and send it back to the blood. So it causes calcium reabsorption in the kidney. So if a person has osteoporosis, is it good for them to have increased parathyroid activity? No, because it's the bone breaker. If we have osteoporosis, do we want to further break down bone? Definitely not, right? So people with osteoporosis will take a calcitonin spray, nasal spray. I forget the name of it now. I haven't worked in the nursing home in a long time. But calcitonin is the hormone that acts opposite of parathyroid hormone, and that is the bone maker. So calcitonin is the bone maker, and that inhibits osteoclast activity. But it's not as powerful as parathyroid hormone is. Because again, the body doesn't care about the skeleton. You know, there's a list of priorities to keep the body going, right? Heart and brain are number one. And there's a lot of mechanisms to protect heart and brain function in the body. The bone mass, not that important on a minute-to-minute survival basis, right? Our bodies are meant to survive on a minute-to-minute basis. So heart and brain are number one. Skeletal, that's if there's extra, right? If there's extra calcium floating around, let's put it in the bone. That's what's going to happen. So if there's not enough, then we're going to go get it with the parathyroid hormone. So calcitonin will inhibit osteoclast activity and prevent that breakdown in people that are at risk. So it's not quite as active, but it also works. So statins, these are cholesterol medicines. Those have been found to also increase osteoblast activity. So that's kind of a side note for people that take a cholesterol pill, like Lipitor. Maybe you've heard of that on the television. That stimulates osteoblasts. So we know that our bones store that calcium, and that's where, again, if we need to get it, it gets too low in our blood, we're going to go grab it. But if we don't have enough calcium in our diet, our bones become too flexible, and with the weight of gravity, the bones start to bend, and that's called rickets. And we see these in poor countries where they have poor calcium and vitamin D intake because of just, not enough food in the environment. And then osteoporosis, number one area that the break occurs, causing someone to fall and break their hip, is the neck of the femur. Because you think of the whole torso is sitting on that angled neck of the femur, and if the trabeculae are broken down and those holes in the bone become much bigger, the trabeculae are broken down by osteoclasts to release calcium to the blood. Instead of looking like this at the neck, it looks like this, and over time it cracks. So very, very important that our elderly don't just sit in bed all day and not get up and walk around. It's easy sometimes when you have a patient that's sick and wants to lay in bed and take, their medicines to help them sleep and the oxycodone to relieve pain. But we really need to get them up and walking to stimulate those muscles, to pull on the bones, and gravity to work on those bones to build more trabeculae. But when we do a broken hip like that, they're going to, in some cases, they remove the whole head of the femur and the neck and put a brand new one in there, so there's no more risk of breaking that bone. But a lot of people, when they're really elderly and thin and weak and they break their hip, it's a number one cause of death among the elderly. You have a little old lady puttering around in her apartment, or farmhouse, or wherever she lives, breaks her hip, goes into the hospital, doesn't do very well in the hospital, recovering very weak, having difficulty standing after the surgery because of the stress of the surgery. Then they go to a nursing home and they don't get stronger there, and then they pass away. So we always tell our patients to just really be careful, when they're walking around their house, making sure they're using their walker and that they're strong enough to go home after other procedures. If you send someone home after just even a minor surgery like getting a pacemaker, if we send them home too soon and they're not demonstrating they're strong enough, they'll go home and fall. That'll break a bone in a hip for sure. So that's what the importance of physical therapy and occupational therapy. If you're going into either one of those fields, your job is going to assess, is this patient safe and ready to go home? And if you don't assess that appropriately, they're at risk of falling and not surviving that, because it's a big deal when we break the hip. So as we age, what do we get to look forward to? This is, again, dependent upon how active a person is. So bone matrix decreases. The matrix, again, is the calcium and the collagen. That's going to decrease over time, making bones at risk for fracture. And as a result of that, if the bone matrix decreases, then obviously the bone mass decreases, and we're going to see increased bone fractures. And then if we see a lot of fractures along the spine, it causes the spine to bend with gravity. Now you see people start to lean forward, and they have that big bump on the back. That's called a kyphosis, when it bends, when the spine bends outward. And that's a sign of osteoporosis. It's small fractures of the vertebra. So it's really important that we have people stand upright when they're walking in the hallway, because people tend to start to bend forward and those muscles start to relax and they're not able to stand upward again. So when you start to see that happening, you got to tell your patients ears over the shoulders, or nose behind the toes is another thing that they can remember when they're walking, because we've even had young people that are injured and they're really weak and they walk like a little old person in the hallway with that walker. You got to tell them to stand up. Look out. It helps expand the lungs, too, to stand up properly.
You say
Butt forward?
Yep, stand as tall, butt forward, push your hips forward.
Oh, hips forward. Yeah. That works, too. So, yeah, the biggest thing we can do, though, as young people is make sure we're getting enough calcium and vitamin D and vitamin C in our diet, and weight-bearing activity. Weight-bearing activity is so important. And as a society, we tend to be a sitting society. There's lots to do sitting around, right? And our phones have made it even worse. If you're bored, in the past, maybe you would have gone to the mall, or you would have gone for a walk, or you would have, gone out with friends, but now we just sit on our phones, and that is putting us, really at risk. And we got to get our patients walking. And as a past CNA myself and a nurse now, it's hard sometimes on a busy shift to get our patients walking in the halls, right? Because it's like, oh my gosh, and then they get them ready to go for a walk. I think I'm going to go to the bathroom first. And then they sit in there. Maybe they're constipated, so it's 10 minutes in the bathroom, right? And then you get moving, and you get down the hall, and they're moving really slow. So it's understandable that it pushes us as healthcare workers, but, trying to keep on top of our patients' health is really important. So weight-bearing exercise for women after menopause, hugely important. If we just hang and sit around after menopause, again, we're at risk. If I look at a 90-year-old patient that's getting up to the bathroom and on their own, I always ask, what do you, and I always like to ask, too. It's like something I always do because I'm always curious. I'm like, gosh, you move so well for your age. What do you attribute to that? Were you really active as a young person? And every single time, it wasn't just luck, it wasn't just, there's a little bit of luck in genetics, but a major component of being active as an elderly person was they had an active lifestyle as a younger person. And it didn't necessarily have to be exercise. I had one lady, her and her husband owned a butcher shop. So they were lifting heavy meat from the counter to the back to the freezers, and they were, just moving around all day long on their feet. So, and some were farmers, just active farmers. But now if it's a farmer who sits and eats high-fat foods, does their milking in the morning and night and sits around the rest of the day, then that's not going to be good. So we need to have that weight-bearing exercise. So the dosage, this is being updated. I should update this number, this 800 milligrams of vitamin D. This was the standard dosage, but now we have found that we are all under our values on a regular basis of vitamin D intake. So they're recommending 2,000 to 5,000 now, depending on the individual. So that has changed, and it's ongoing. We're not even sure 100%. Some people are getting 10,000 as like a weekly dosage until they get their numbers up. So vitamin D has receptors on there's receptors for vitamin D on every cell of the body. We're not even sure of the function of vitamin D. We do know that it is linked to depression. People have low vitamin D levels tend to have depression, or vice versa. People with depression tend to have low vitamin D levels. We know it has a link to immune function, so people with low vitamin D tend to get sick more often. And we know it's important for calcium reabsorption. So, and that's what we know. There's things that we don't know. Some people have looked at vitamin D and said, is that linked to multiple sclerosis? Because we see MS in areas where there's less sunlight. And we see MS, there was some link that people thought people that are drinking milk out of the bulk tank on the farms that aren't supplemented with vitamin D, is that a risk factor? So there's lots of things we don't know. So it's best to just make sure you're getting enough vitamin D in your diet, right? So like I said before, they're small little pills and not that expensive.